Well, we're excited to talk, obviously, always more about mental and behavioral health from my perspective. So this is my jam, and so I can talk about this all day, every day, if you guys want. But there's tons to talk about, and I've modified today's presentation a little bit just based on some of the feedback that we got from the first session. And so we're going to incorporate a few things to just try to answer some of the questions that came about, and also talk a little bit about the impacts of social media and mental health, which is adjacent to management of mental and behavioral health, and was a question topic that came up quite a bit in some of the questions. And so we'll spend a little bit of time on that as well. We're going to try and wrap up about 10 to 15 minutes before the end of the hour so that we give time for questions when we're finished today. Um, Next slide, please. So, as far as our learning objectives, we're going to be talking a little bit about autism. We're going to be talking about formal thought disorders, primarily in the form of psychosis. And then Cindy's going to talk to us a little bit about trauma. And then we're going to spend some time talking about social media's impact on today's youth. Next slide. So obviously, autism is something that we're seeing in increasing numbers across the board, and so I think a lot of times it's important for us to just define what autism is, and it really is a neurodevelopmental disorder, and it is characterized by a few things in particular. Number one is challenges with communication. Number two is difficulties with behavior, and then three is social functioning, deficits in social functioning that always begin in childhood. So we do not see autism come about later in life. Autism is something that must be rooted in childhood. And as the name implies, spectrum gives it a wide range and something that has come about in recent years. So if you go to that next slide, this kind of gives us, and it's very wordy and a lot. And so I don't want to focus on too much here, but it just shows how autism defined has changed over time. And I think at least in part gives an explanation as to why we're seeing increasing number of kids diagnosed with autism. Part of it is because the criteria have expanded significantly. And so individuals who would not have previously been diagnosed with autism but might have been called something else now fall within the autism spectrum, and certainly is part, not all, but part of the reason why we see this being diagnosed at increasing numbers. What's interesting is if you look to the far right in the DSM-5, which was birthed in 2013, they came up with levels of autism. So level 3 meaning the most severe, level 2, and level 1. As of the last 6 months, the experts in autism are actually saying that we are no longer going to use leveled diagnoses. And so they are just going to give individuals a diagnosis of autism spectrum disorder, irrespective of the level, but will maintain the qualifications of with language impairment or intellectual impairment. And so once again, they're changing how this is going to be kind of qualified once again. Next slide. Something that I think is really important when we're dealing with autism is to talk briefly about medications. And the reality is that because a lot of these kids are prescribed medications, and we can argue back and forth or, one way or the other, whether or not medications are indicated or should be prescribed all the time. But the reality is that a lot of these kids are put on medications. And so I think it's important to at least touch on it. And we do know that a lot of these kids are over medicated. And so the two most commonly used medications in kids with autism is Abilify and Risperdal. And then a few that you may see in your role as school nurses is Zyprexa or olanzapine, Haldol, Thorazine, or chlorpromazine is the generic name for it. And then a couple of other mood stabilizers, valproic acid and lamotrigine, are also commonly prescribed or used medications in kids with autism when we're doing with behavioral disturbance in particular. Next slide. And so the reason I wanted to bring that up is because I want to talk a little bit about what we want to look for in the classroom setting or in the school setting. And so here's the things we're hoping to avoid when individuals are prescribed medications: lethargy and fatigue. If kids are severe to the point of like sleeping in class, zoning out, or what I call zombifying, they become emotionally blunted, that is a poor response to medication. Never should be what we're aiming for to do with our children. So if we're seeing those things, those are things I would recommend reporting to families and letting them know, hey, we're observing this in the classroom. or at school, and we're concerned about it. Increased appetite. We're hoping to avoid this, but kids can become hyperfixated on food with some of these medications, and that in and of itself can become a behavioral problem. So if they become fixated on food to the point of aggression when food's not given, that's a problem. We don't want them on a medication that's going to do that. If they have weight gain, so greater than 10% of total body weight in 6 months or less is considered unsustainable weight gain. That is a reason to come off of medication. Akathisia, which is restlessness, is like almost, as I put in there, ants in your pants. You'll know if you see somebody with akathisia. It's like they cannot sit still and they will pace constantly. It is a side effect that's pretty rare in kids, but it does happen and it should be avoided. So again, a reason to stop medication. Tardive dyskinesia are those facial movements. It's almost like a lip smacking movement. That is also really concerning and irreversible. And so, if we see that, we would want to stop individuals on medications almost immediately in order to avoid that becoming permanent. And then severe skin reaction specific to lamotrigine, but that can be problematic and actually is a medical emergency. So those are all the things we're hoping to avoid. I'm not trying to scare people, but I do think it's important that we talk about the risks of medications because unfortunately, oftentimes kids are prescribed medication, have side effects, and then they're prescribed another medication to help treat that side effect, and it becomes this kind of snowball effect. And again, I think it's something that we really want to avoid. So what are we hoping for? That if we're going to use medications for the pure intent of what they're intended for, we're hoping for decreased aggression, we're hoping for increased cooperation with like rules, with boundaries, with transitions, and that they become a bit more responsive to that redirection when it's required. And the thing that I have to tell parents every single day in my clinic is that there is no such thing as a magic pill. If we came up with that, we would all be really rich and could probably all retire, but that just doesn't exist. So all we're hoping for is improvement in symptoms, but we have to maintain realistic expectations about what medications can do, what they can't do, and the risks that are associated with treatment. I'm a believer in least amount of medication for the least amount of time possible. So we're aiming to put them on the least amount for the shortest period of time. And that's what that last bullet is emphasizing. Once we reach stability of that aggression or that irritability or emotional dysregulation for a period of 3 to 6 months, literature suggests that we should taper off of medication. So we're looking to stabilize and then come off. The challenge is that parents become really resistant to that because something's worked, something stabilized my kid, and I understand that, but that's a conversation that we have to have all the time. Next slide. So what can we do? The most important things is that we want to ensure that students have adequate support, so they have an IEP or a 504 in place with those appropriate pullouts in classes. So whether it be ABA therapy, which I know in some districts is allowed, some are not, speech, OT, PT. So we want to make sure that we're accommodating those needs as indicated, whether that be in the school setting or for outside resources or outside services. And then paraprofessional support, as you all know, is just paramount of importance in our classrooms. And those individuals work tirelessly for these kiddos who have the greatest need, without question. And I do think another thing is providing schools with positive feedback, or parents with positive feedback, rather, uh, or feedback in general, but we want to give them positive and the negative feedback. I think a lot of times we emphasize the negative, and that can be pretty daunting or distressing to parents. And so it's really good to throw in some of the good things or positive things that we're seeing from the kids as well. And we want to be gentle in our approach with observations, not only directly to the students, but also to the parents or family members when we're communicating with them. Next slide. So I want to talk transitioning away from autism now. So autism is something that's really important and something we really need to be mindful about. But we're going to transition a little bit over to psychosis, what I call formal thought disorders. And I think a couple of definitions are helpful, and then we'll kind of jump into things a bit. So psychosis is where we have a severe disruption of thought and of behavior that often results in the loss of reality. And so what happens is that individuals can become so distorted in their thinking that it's really difficult for them to discern what is true and what is not real. And that can come in various forms, which we'll talk about here in just a minute. Um, And the primary symptom, this primary psychosis occurs primarily in schizophrenia. Sorry, that is a poorly worded bullet, and I apologize. But psychosis can also be present in mood disorders, in neurological disorders, in intoxication from substances, and secondary to trauma. Next slide. So psychotic-like experience are described by approximately 8%, nearly a tenth of 13 to 18-year-olds, and almost 17% of 9 to 12-year-olds. You're thinking those numbers are outrageously high, and the reason you're thinking that is because it's true. It is, I guarantee you that not all those individuals have a psychotic disorder or like a schizophrenia spectrum disorder. Next slide. So let's look at the criteria for a second, and you can kind of click through all of this just to pull it all up. But we have to have greater than or equal to one of the following four: delusions, hallucinations, disorganized speech, and grossly disorganized or catatonic behavior. One, two, or three, you have to have one of them. So whether it be a delusional thought process, hallucinations in the form of auditory or visual hallucinations, or what we call disorganized speech, which is just like they're speaking nonsense. You can't even like follow their dialogue or their conversation. And as always, disturbances persist for greater than a day to less than a month for a brief psychotic disorder, 1 month to 6 months for schizophreniform disorder, and greater than 6 months, it becomes schizophrenia. Next slide. So this is where I wanted to get into the prevalence. I wish I would have put that slide one back, but because the prevalence of schizophrenia is around 1% for the general population. So if you think about that 1% for the general population and then 17% of kids reporting psychotic symptoms, you can see that those two things don't compute. So what we're seeing is, okay, a lot of kids are complaining about psychotic-like symptoms, yet they don't have a diagnosis of schizophrenia. And less than 4% of those are what are called early onset schizophrenia, or EOS. Early onset schizophrenia is individuals who develop schizophrenia before the age of 13. No, 18, before the age of 18. And the estimated prevalence is 0.02% of the population. It's a little bit more common in males than females and gets to about a 1-to-1 ratio in adulthood. And then that COS, which is childhood onset schizophrenia, is even rarer than early onset schizophrenia. Childhood onset schizophrenia is kids who develop symptoms at less than 13, whereas the early onset is less than 18. So again, the reason I included this slide at all is to emphasize this is so, so rare. So when you hear kids complaining about hearing voices or seeing things, it requires additional exploration because it very rarely is like true schizophrenia. Next slide. So non-psychotic presentations that are misdiagnosed as psychosis, let's go through these. You can just kind of click through, or good, it's just one thing. So one of them is just normal overactive imagination, where kids have imaginary friends. That is very normal. We call that normative behavior. So kids that have imaginary friends is just consistent with development. Some will have like vivid fantasies. They can perseverate. Um, they can have depression or a bipolar spectrum disorder with psychotic features. So that means that they'll develop some of these symptoms only in the context of feeling or of a significant depressive episode, or when they're manic in a bipolar episode. Some individuals will have obsessive thoughts like related to OCD or anxious distress, and those thoughts can be so pervasive or so present that they can then almost feel delusional, or it can get almost where it seems um, in it, different than reality, outside of reality. And then there's dissociative experiences and hypervigilance that are related to PTSD or trauma. And those are things that we need to really be sure that we're looking out for in our youth. And then they can have just transient or stress-related paranoid ideation, which is more consistent with like personality construct or personality disorders. Grief can also present with some psychotic-like symptoms. Next slide. What are clues that hallucinations are non-psychotic? So I think a few things that are important to note. Symptoms that are situationally specific. So if they're only hearing voices when they're angry or at bedtime, or when the lights go out, they see shadows. That is usually non-psychotic. If they're overly elaborate or detailed, so most individuals who have a schizophrenia or a true formal thought disorder are unable to provide a lot of elaboration or detail, and because they are so distressed by those experiences that they try to avoid them and they're not studying them in detail. Um, they occur absent of any overt evidence of a thought disorder. So it's like these happen, but yet there's nothing else to indicate that we're seeing schizophrenia, for example. They're not interfering with functioning. So the people will tell you, yeah, they're great. I listen to those voices all the time. They don't bug me at all. It's, I can go about my day normally and they're just around. That's uncommon. It's not affecting other areas of their life, and it's not accompanied by delusions. So those are a few things or a few clues that help us say, I'm not certain that this is psychotic. Another thing that you can look out for that I didn't put in here, but I meant to, is that if they can't identify a way to distract themselves from the voices, that's oftentimes a clue that they're non-psychotic as well. Individuals with true psychosis, true voices, true hallucinations, they will do anything to get rid of them because they cause so much distress. And so they'll find ways that they can get rid of them, tamp them down, reduce them in some capacity, and should be able to identify those things to you. If they can't do that, that typically means that something else is going on. Next slide. So, what can we do if we're concerned about this? So, number one, do we have concern about some sort of thought disorder, some sort of psychosis? Number one, we want to show empathy without providing reinforcement. What I mean by that is we want to acknowledge that, wow, this must feel really distressing to you, or I'm sorry you're really distressed by this, without giving into. Sometimes kids are attention seeking, and so we have to be really careful with how we address it with them. Oh, that must be really distressing. I'm really sorry you're going through that. We'll hopefully we can figure out what's going on, right? Versus saying, oh, come sit in our office anytime you're having that and let's talk for 2 hours. And you can, if we give into that too much, we can sometimes reinforce it unintentionally. We want them to follow up with primary care provider because they need a full workup, which includes labs and all sorts of things. Anytime kids present with a psychotic like syndrome or symptoms, it needs to be worked up first before we put them on medications because a lot of times there's a medical reason or medical cause for this. And then we want to consider maybe having them meet with the school counselor or an outside counselor for support or to explore it further with them. And then the last thing is that we want to make sure we're collaborating with parents on this. What are you guys seeing at home? Is this a problem at home? Do they seem to be responding to these voices that aren't actually present in your home? So it can be a great way to kind of say, oh, this is happening in multiple environments. That's a little bit more concerning. And the reason we want to do all these things again is because there's always that risk of something else going on. And I think one of the number one things that it can potentially be is trauma based. And so that's why we want to transition over to talking a little bit about trauma and PTSD, because this is a way that sometimes psychosis can present in my experience. And so anytime I have kids complaining about hearing voices, seeing things, we want to make sure that we understand if there has been any trauma going on in their lives, because a lot of times this is a response of the patient's effort or the resiliency and their effort to try to avoid the emotional turmoil that trauma can cause. Next slide.
So when we talk about children and trauma, trauma can come from several different ways. So it could be from abuse or neglect. It could be from a loss. They've lost maybe it was their parent who's passed away. Exposure to violence, and that can be in the home. Maybe it's when they go to daycare after school. Could be community-based. Maybe they were, at a bad scene where there was a wreck and they saw something horrific. And then just having ongoing family stressors can cause trauma. Children respond to trauma differently depending on their age, what they've experienced, how they're treated at home. And when I talk about age, there's a difference between chronological age and developmental age. And when I'm talking about that, an example would be like a child that's had to take care of themselves since they were very young. They may do things that other kids at their age don't do. So maybe they're 7 and they're cooking their full meals because they've always had to cook meals for themselves. Um, but when you sit down and play a game of tiddlywinks, they don't understand how to take turns because they've never done those things. So their chronological age is much higher than their peers. So their response to things can look very different. And trauma can impact their ability to regulate their emotions. Their behaviors are sometimes instamatic, so they're not controlling them. It's just their learned behavior and it's automatic. Um, and it does and can affect their physical health. It can result in that fight or flight of a child for a response. And in every aspect of their life affects them, but especially when they're trying to learn. It's very hard to learn and sit in a seat during the day if we're always in that reactivity type response or waiting for the next thing to happen, or even just loud sounds, changes that can affect these students. And school nurses are often in a very unique position because they can recognize these early signs and we can help a student who's presenting with trauma to be able to get their health concerns either disclosed or at least get some of the emotional distress and things that are going on. We can connect them to the sources that can help them. And then long term, that helps academics, but it helps their life. And I think not only is there consequences with their immediate health, long term, we know what trauma can do. It shortens our life. The comorbidities are countless. Next slide. So things that behaviors and emotion indicators, trauma may present suddenly or it can be gradual. So depending on what's going on. So we may see a child that's withdrawing from their peers. Maybe they were a student that was really interactive in class and then all of a sudden they're not interacting. They're not giving the answers to the questions. Maybe they're really impulsive. A child that normally doesn't, talk out of line or is pushing on other people or doing things. Maybe they're starting to fight with their peers or they're the one out on the playground that causes the problems. They might be the kiddo that something happens in class, but the reaction to what's happening is completely out of line. And so we start to see that. Maybe we're seeing some anxiety, some depression or irritability. And I think it's really important that you discuss with students, trusted adults, and understanding that teachers and counselors can be trusted adults, their coaches, their bus drivers, their lunch ladies. Having those relationships formed can really help with resistance and avoidance of having lifelong problems. And those subtle fluctuating things that happen are patterns over time, and we need to be able to recognize those rather than just isolating them as single events and being able to consider that maybe trauma is the underlying factor. Next slide. So when we look at students that are affected by trauma, they may report more somatic complaints. They're the one that comes to the office every day with a headache. Maybe they are constantly complaining about being nauseated, or they're constantly, they have brain fog or fatigue. They're the kids that have poor concentration in the classroom. The teacher's always sending them up because he doesn't listen. He can't follow through with what I'm telling him to do. We can see a decline in their academic performances. Maybe they're having a hard time with their grades being maintained. Maybe they don't even want to be at school. So they may be the ones that are tardy to classes. Maybe we're finding them in the hallways or hanging out in the bathrooms or taking extra long time at lunch. And so the increased visits to the nurse's office, the vague complaints, and then making sure that those students that are seeking that we're collaborating with the teachers. And then also, I think it's important the counselor and your principal are involved, that we're kind of combining what we're all seeing, because I think we're probably all having touch points with these children. And if we're not communicating that, we're missing something. Next slide. Oh, come back one. And so what can we do as school nurses to respond and support these students? Um, we need to observe what's going on, and then, of course, document what we're seeing, communicate those concerns, the patterns that we're seeing appropriately to the school staff. Confidentiality, of course, is very important. And then remembering that we're mandated reporters. So if we're seeing any injuries or there's patterns that we're worried about, um, we have concerns that that's reported. We need to be providing that calm, predictable, supportive environment, and that not only in our office, but if you're taking them out into, if you have a room that they go to settle down or to regain their composure in the lunchroom at recess. And I think it's really important school nurses are out in the lunchrooms and that we're out on the recess duty because we can see a lot out there. They don't have to tell us what's going on. You can see the student that doesn't have a friend or the student that gets picked on. And then collaborating with teachers and counselors, the families, providing resources in our rural areas. Resources are a lot harder to come by, but they're there. If you really look into ways to get those kids plugged in, um, and maybe it's plugging them into another family that's doing similar things, whether that's going to baseball practice or they're, doing band or FFA. And then being consistent, compassionate with our responses, I think is super important. Um, I think as a school nurse, we should, provide some trauma training to our staff so that they understand it. And then just being a good influence. It's really easy when a kid is exploding in class to look at the behavior and not realize that that is a student that's in crisis. And so really stepping back and looking at the whole picture. So I want you to imagine for a minute that we have two water bottles. And in one water bottle is 7-Up, and in the other water bottle is just water. So in the water bottle, his name is Alex. And Alex lives in a home where the routines are pretty predictable. When Alex feels upset, he can go to an adult that listens to him and helps him calm down. He has learned that when something unexpected happens, like a loud noise, a schedule change, if he's uncomfortable, it will pass and that he will be safe. And then we have the 7-Up, and that's Jordan. And Jordan has experienced really some scary and confusing times in his life. He has lived with lots of yelling, sudden changes, abrupt moves, times when adults couldn't keep him safe. And Jordan's brain has learned that he always needs to be on alert. He needs to be ready to go, and that hard situations are what he deals with. And he doesn't always know when he's going to get his next meal. And he doesn't get great sleep either. So we're in class, and the Alex and Jordan are in class. The surprise drill goes off, and they're both sitting in their seats. And Alex jumps a little, but he covers his ears, and he's able to take a breath, and he's able to get in line for that drill. And he might think that that was really loud, and he feels okay in a few minutes. He knows that he can trust his teacher to get him out of the classroom. He feels safe at his school. Now let's look at Jordan. Jordan, when that bell goes off, he freezes. He starts to cry. He might even yell out, and he runs out of the room, and his heart is racing. It's hard for him to even listen to the adults around him that are telling him to calm down. He, from the outside, is overreacting and maybe misbehaving when people are watching him. But in Jordan's brain, it's doing something completely different. He has experienced trauma, and his brain is trained to look for the danger. He is not trusting of the adults at the school, and he does not feel safe. That loud bell tells Jordan's body, you are not safe, and then his body reacts without him even having the chance to think about it. He's not choosing to act that way. It's just his way of his body to protect him. So I think it's really important that we understand why kids can act differently, and we need to stop asking what's wrong with the child and start asking what has this child been through and how can we help this child. But my takeaway is that when kids are misbehaving or the behaviors aren't what we are expecting, that we don't put them in a glass jar and figure out like these are just the bad kids. We need to look at what's really happening to cause what's going on in the classroom. And sometimes if it's ADHD, maybe we just need an alternative. He needs a pedal bike in the classroom. He needs a seat that he can move around on. Maybe it's anxiety and he doesn't know how to handle it. Maybe it's a walk down the hallway, go get a drink. Maybe that's, he's getting counseling. But if it's trauma, we need to also think about what we can do and what we can put in place and how can we make this child feel safe. It can significantly impact children's behaviors, emotions, and physical health. And that as school nurses, we need to observe and document what we're seeing and then respond to those students. And then collaboration, I think, is some of the most important thing we can do, allowing to get resources to those families, get resources for the kids, and then just how important early recognition is in all aspects of mental health.
Thank you, Cindy. That was super, super helpful. And I think really important for us to be looking for in the presentation of our kids in all of the things that we talked about last month and the couple of topics that we touched on this today as well. We're going to transition for just a few minutes, and I've got tons of slides on this. And guys, I present on this at probably too much at a national level and local and state level. And so I'm pretty passionate about this work, but we're just going to very, very briefly touch on it. And I will be happy to get into more details at a future date if people are interested in that. So I've got lots of slides, but we're going to blaze through them. So adolescent and digital use, the statistics, and let's just pull all of those up because there are several boxes here. But I think it's important to talk about a couple of things. Approximately 95% of adolescents in the United States have at least one mobile device that is their own, and 89% of adolescents own a smartphone. Children that are ages 8 to 12, so this is 8 to 12-year-olds, are spending approximately 4.5 hours a day using media for non-school purposes. So this is purposes outside of school. And then teenagers are using about 6 2/3 hours of media time outside of school. That is an exorbitant amount of time that kids are using devices. Next slide. And what do we see as a consequence of this? And we're going to look at some graphics in a minute, but here's just some ways that this is put into some words. But what we're seeing is that body image is worse for individuals who are using it the most prevalently. There's higher rates of mental health that are rated as poor or very poor, increased rates of suicidal ideation, etc. And so what we're finding is that as social or media in general, and I oftentimes will say social media, but media in general is increasing, mental health is decreasing. So let's get to some of the statistics. Next slide. And just for you guys to kind of put in the chat box, I'd love to hear from you a little bit about what factors you feel like shape the mental health of young people. It can be anything. It doesn't have to be media driven, but in general, what factors shape the mental health of young people? I love that first response, healthy adult examples and peers. Okay, let's move on. That is amazing. Thank you for sharing that. I'm not going to get into this, so let's just skip this slide. There's a lot to talk about there, but we just don't have time. So now some of the statistics, and I want you to pay attention to that darker gray section on each of these graphics that I'm going to show. The reason that that point in time is particularly important from 2010 to 2015 is because this is when we saw the advent of social media. So the development of social media platforms became way more prevalent around this time. And I believe it was in 2000, maybe it was around 2011 where the selfie became a very, very commonly used thing in the world. And so you'll notice in many of the graphics that I show you that there are steep inclines in this dark gray section. So this first statistic is talking about major depression among teens. And so you can see that since 2010, there's been a 145% increase in the report of teens, girls who report major depression, and 161 increase in boys. So boys have actually gone up by a higher percentage, though their rates overall are lower. Next slide. In this next graphic, we see mental illness among college students and the increases in a number of disorders, anxiety and depression being the most prevalent, with an over 100% increase in depression and about 130% increase in anxiety. Many other disorders have increased over that time frame as well: ADHD, bipolar disorder, anorexia, etc. But the two most prevalent by and away are depression and anxiety. Next slide. Anxiety prevalence by age. I think this is pretty telling, in particular as it relates to our youth. But we've seen a significant increase in anxiety disorders in our 18 to 25-year-olds. We unfortunately don't have data in the younger kids like adolescents, but I anticipate that that number would be even higher. But anxiety prevalence in 18 to 25-year-olds increased by well over 100%, 26 to 34-year-olds about 100%, and then it reduces. So those 35 to 49-year-olds only a 52% increase, which is still significant, and ages 50 plus a decrease in anxiety since 2010. Next slide. Emergency room visits for self-harm since 2010 up 188% in girls, and up 48% in boys. Next slide. Suicide rates, again, massive increases by almost 100% in boys and about 150% in girls. Next slide. And here is so why about this highlighted gray area. And as you can see, that second to far left or far right line is the advent of social media, which just took off in around the year 2010, and smartphones in about 2012 or 2013. So this is when we started to see these massive increases in those technologies, is right in that dark gray area that I was showing in all those other graphics. Next slide. So why are we seeing this increase? And I want to emphasize what I said before. The rise is concentrated in disorders related to anxiety and depression, which we classify as internalizing disorders. There are disorders that many times we as parents, as teachers, as peers can't see on the surface. They're internal, they're inside, so they're not distinguishable by the naked eye. And it's concentrated in Generation Z in particular, and in Generation Alpha, and with a bit of spillover into some of the younger millennials. Next slide. Is there a generational divide? And going back to that slide I showed earlier about anxiety prevalence, I think we can argue that there certainly is. I wish still that we had numbers, and those numbers are being tabulated now, so I think we'll have them in the next couple of years. But these numbers are very concerning, and they're even worse for our kids who are between the ages of 14 and 18. Next slide. So what are the concerns significantly? This is with respect to social media or media use in general. It has a negative impact on physical activity and physical fitness. There's a decreased ability of kids and young adults in their capacity to interact with others in real life, face to face. More kids who don't feel comfortable ordering at a restaurant, more kids who don't feel comfortable making a telephone call. All these things are becoming bigger barriers and hard problems. Challenges with eye contact, avoidance of others, and as I mentioned already, fear of making a phone call. Next slide. So there's a book that's called The Anxious Generation by Jonathan Haidt, and this book is pretty revolutionary. It can be a bit scary when you read it because it talks a lot about the rewiring of the brain that has happened as a consequence of media and social media in particular. But the argument stems from what that picture depicts on the right, which is transitioning from what we would term a play-based childhood into now a phone-based childhood. Most of us, when we grew up, were outside playing with our friends constantly. You know, it was hard to get you to come in, and except for maybe when it was time for dinner. And part of this has been a parenting shift too, but then there was like this thing of helicopter parents and parents becoming more concerned about their kids. And I think just as a consequence of the world we live in, at least in part. And so parents became more comfortable with having their children indoors and inside and protected from the world around them. But as a consequence of that, we started seeing this shift to electronics and technology. It was TV, video games, and now over to smartphones, tablets, computers, and laptops. Next slide. We're going to step through the rest of this very quickly. We'll skip this slide. So there's four things that, well, let's skip this slide too. Sorry. There we go. There are four things that are kind of identified as the foundational harms of social media. Number one is social deprivation. So, actually, believe it or not, kids who are spending time on social media are, number one, more likely to suffer from those internalizing disorders that I mentioned, depression and anxiety, but they're also more likely to experience social deprivation. Many of them will argue it's the only way I connect with my friends, yet the data shows us that they're actually socially deprived. And so there is a disconnect that kids are making between real social connectedness and what they're getting on social media. It doesn't compute and it isn't the same. Next slide. Sleep deprivation. This is a massive issue. Kids are spending times on screens up late, up early, so that they can have time to look at screens, to communicate with friends, to look at social media before school, after school. And as a consequence, their sleep behaviors are much worse. Next slide. Attention fragmentation. So this is something I think that we oftentimes don't think about, but kids really struggle with attention these days. And yes, some have ADHD, but I think a lot of it is that instant gratification that they're getting from using social media and devices. Next reel, next reel, next reel, and their attention then is so fragmented because they want to shift to the next reel when a teacher's talking for more than 5 minutes. And so they're like, they want to swipe up on the teacher because they're wanting to move on to the next topic and they don't. And then they become distracted by whatever else is going on in their environment. This isn't an issue with ADHD. This is an issue with media. Next slide. And addiction. There is tons of research that is coming out right now that is suggesting, not surprisingly, that media is addictive and that social media in particular is leading to addiction. It's my prediction that there is going to be a number of new diagnoses that come out with the next statistical manual specifically related to media use and addiction. And not only that, but actually media-driven psychosis. So these are really big concerns that we have. Let's go to one more slide before I wrap up. So, four needed reforms that come specifically from this book, The Anxious Generation. And these are things that I stand by and I talk to every single family I see in clinic about. Number one, kids should not have smartphones before high school. There really is no indication for them. If they need a phone, they can have a flip phone or some other, a watch, some other sort of device that allows them to communicate. I do understand that kids are busy. I understand that sometimes they're in competitive sports and gone from school a lot. I have two of those in my own home, but we still need to be limiting their use or access to smartphones before they're in high school. There should be no social media before 16. I would argue 18, but 16 is what most of the data suggests. So no social media before age 16. Schools should be phone free. And I know that you guys have no power over this, nor do I. But in an ideal world, schools would be phone free. They would be like turned in, locked away, something as soon as they walked in the door. And I know some schools are trying to implement this policy, but it's really challenging. It's really difficult. And I know that. And then far more unsupervised play and childhood independence. We need to let kids go outside and be kids again. And if they want to go to the playground one block away, they should be allowed to do that. And it can feel scary, but there's so much good that comes from allowing kids to have freedom and be around other kids. And we just see a lot of evidence for that. I'm going to finish. We can probably finish with slides, but I'll finish with one last point. Um, the three biggest pillars in mental health are sleep, appetite, and exercise. Those things are more important than anything else we can do with kids. We need to ensure they're getting adequate sleep each night, which for most kids 18 and under, it's at least 8 hours a night. They need to be getting good, proper nutrition throughout the day, making sure they're getting that balanced diet that we always talk about. But kids oftentimes are skipping meals, avoiding meals. Why? Because they're in the middle of a round in their video game. The third thing is exercise. Really, the science suggests that they need to be doing at least 90 minutes of aerobic activity a week. So I tell kids, break that up however you want. 3 30-minute sessions a week, 6 15-minute sessions a week. I don't care how you get it, but you need to get it. There's so much data to support its benefit in the mental well-being of children. So as we're wrapping up and transitioning to questions, there's just a few points I wanted to kind of point out of questions that kind of came up when we had some folks deliver some questions to us. Number one, somebody asked about the proportion of kids that I prescribe medications to that I see in clinic. It's a really good question. I would argue that my numbers are probably higher than the general population because as a specialized psychiatrist, when I see kids, oftentimes they are in crisis and they have been treated and been in therapy for 6 months and have been trialed on medications. So I would probably say I probably around 60% of my kids are started on medications within the first few visits that I see them. However, more often than not, I'm actually seeing kids who come to me on a very messed up medication regimen, too many medications, they're over medicated. And so I'm actually way more frequently trying to clean up medications than I am trying to start kids on medications. But the reality is that we do know that there are pros and cons of using meds for treatment of these conditions. And so we have to always be weighing those things out. But I would recommend whenever you interact, engage, or talk with families that they are aware of not only educating about the needs sometimes for medications, but the needs to try to taper off of medications when literature suggests that they should. And so I think if we're talking to families about that ahead of time and saying, hey, we're going to do this, but it's going to be temporary, that helps to reinforce that when we get to the point where we want them to come off of treatment. That's all I have. So we'll open it to questions.
I just want to thank you again. This is amazing and awesome. The last two sessions. Cindy, same to you. Just a huge thank you. I think we've really needed this. I think we can continue to receive this information. Sorry, I'm ahead in the dark now. I was so engrossed in the conversation, I didn't even turn on the lights. But I just really appreciate it. One of the things I think from school nurses that would be helpful is just to hear from you, because I feel we talk about it a lot about that importance of collaboration. But from your perspective, hearing from school nurses directly about what they're seeing in the school environment and how important that can be for you to hear from another clinician or practitioner about what's being seen 6.5 hours a day in the school environment. Can you talk a little bit about that?
Yeah, Tracy, I love that comment. I honestly think we need reform in that way because we need to figure out how to collaborate better. Hearing from school nurses is like so helpful, but it takes physicians taking the time to reach out to a school nurse and say, hey, I'm stuck. I did that the other day and the input that I got was so valuable because the reality is you guys are with these kids all day, every day, right? So even if they're not in your office, you are hearing about them, you are seeing them, you are talking with them, you are hearing from their families. And so I think I can't speak enough about the need for there to be increased collaboration. I work on an inpatient unit too, and so I called the outpatient provider today from a kid at 7 o'clock in the morning because I said I need to know what's going on, and me trying to take this snapshot is just not good enough. So if people want to come together and we can put together a work group or whatever to figure out how to make that happen more readily, I would gladly step up and be part of that.
Yeah, that's awesome. And I think hearing for nurses, it's empowering to hear from the other side that yes, it may be challenging and a barrier to connect with physicians, but once we do connect, it's really important and valuable for both parties. So and most importantly for our kids. So thank
That's
you
it.
for
Yeah.
yeah.
Question about melatonin later in the night, not that I'm aware of. That's interesting data. I would be curious to maybe read more about that, but I don't think that that's true. Key note about melatonin, though, that's important is that kids really shouldn't chronically be on melatonin. So, melatonin is really designed to help reset the circadian rhythm or the sleep cycle, not to be used chronically. It actually tends to wear off effectiveness over time. And so, if you're talking to parents about melatonin, it's really used to help reset that cycle. So if their cycle's broken, put them on melatonin for 2 to 3 weeks, and they should come off. And it should help just reset the natural production of their melatonin, that then they don't have to continue taking this med. I actually think it's a little bit arbitrary and maybe somewhat placebo after a few weeks. I have treated pandas and PANS cases, and let me tell you what a hot topic that is in the world of psychiatry. So you have individuals who are believers in it and individuals who are not. I do think it's a real disorder that kids struggle with. How to help kids with that diagnosis is tricky. So if it's a real true case of pandas, you really should see flaring of symptoms that then should get better as that infection goes out of their system. So right, it's connected with streptococcal infections. And so what we see is in true pandas, if a kid develops a strep infection, they develop like acute psychiatric symptoms, usually in the form of OCD and tics, but it can manifest in other ways as well, behavioral disruptions. And so a lot of times what the treatment course is getting them put on an antibiotic, having that strep, or just letting the strep pass, which it will on its own, right, naturally. And so you can do either one, but you have to just work through that acute crisis, and then things should actually get back to baseline. And so in true cases of pandas, that's what we would expect to see, is that flare and then return back to baseline. So we want to treat basal symptoms, but then we want to allow for that kind of fluctuation that's naturally going to occur. And so we may have to intervene in those instances when we're seeing flare through additional behavioral supports or just accommodating them through those times, because it can be pretty distressing to kids. Yeah, I've seen it too. I have a kid in clinic that is a really severe case of pandas, that I've been treating for 3 years, and has catatonia and also, I mean, it's a really, really tricky disorder. And unfortunately, and not trying to dog on Idaho too much, but we have a lot of physicians in the state that aren't believers in pandas. And so it can be really difficult to get a collaborative team to help treat these kids.
Hey, Casey, is it kind of similar to like the elderly having with UTIs and it creating like
Yeah, that's
mimic?
actually a really great comparison.
Okay.
Yeah. And I think another tricky part about that is, we could talk about pandas for days, but another tricky part of that is that a lot of times they have existing basal conditions. And so they might have a diagnosis of autism or a diagnosis of depression. And then on top of that, they have pandas. And so you want to make sure you're treating the underlying stuff well. And then you should just see these episodic flares. And there's different ways to combat it. Sometimes it's just giving them medications that they can pulse dose. Sometimes it's doing some increased therapy sessions with like ERP, exposure response prevention therapy. So lots of ways to combat it.